Thank you. I think we had, a broad sweep of a set of critical issues that underlie the current addiction challenge that we're facing, and also the prospect that there are solutions within our grasp. I get the prerogative of the chair to begin asking some questions, and we'll have a brief discussion amongst ourselves and then Q&A. But Howard, let me just draw you out a little bit more. You skipped over a couple of pictures, slides about pain. Clearly one of the things that has helped to drive our current circumstance is the fact that opiate drugs have been used very liberally to treat a range of pain conditions. Right. But I think that most agree that chronic pain is not best treated with opioids. But are we adequately investing in the research necessary to really understand how best to manage chronic pain? Are we bringing in to practice new treatments for managing chronic pain? And what are the prospects for being able to better balance the need for pain management with appropriate use of opioid drugs?
Okay, I think I can keep all those in short term here for just a minute. I would say, to answer the first question, that there really is not enough attention being given to the treatment funding of research for treatments for pain. You'll notice there's no National Institute of Pain Research, and so we rely on the generosity of Nora and NIH and others. So it needs to be more of a national priority. I mean, there's been a fair amount of effort expended on this over the last 50 to 100 years, and a lot of drug companies are putting a lot of effort into looking to alternatives for opioids and really haven't come up with things that work that well. But I think that one thing I alluded to is that it may be possible to utilize these effects of opioids as you dissect out the risky side effects. For instance, if we block tolerance and we're able to keep people maintained on low doses of opioids for long periods of time, you reduce the risks of other undesirable side effects, such as constipation, respiratory depression, which can be lethal, and so on. The other piece is that other people have started teasing out the other aspects of opioid side effects, such as physical dependence. There are pathways and treatments. Turns out an anti-malarial drug could be a good treatment for physical dependence, which is remarkable in and of itself. So it may be possible to utilize the best aspects of opioid, which are the analgesia and the rewarding on the side, without running into these side effects that lead to addiction and death.
Maybe can I try to answer it from the perspective of the NIH, because obviously this is something that requires urgent attention. So what Francis Collins has embraced is the concept of what is it that we can do as a scientific agency to accelerate discovery so that we can address the opioid crisis. And so it has three pillars, and one of them relates to the development of pain medications that are effective and have less side effects. And how are we going to do that? Well, one of the initiative is to create a public-private partnership with industry to actually invest in the pre-competitive space in subject teams that could help accelerate discovery. And what may some of those be? There are roadblocks in the development of analgesics other than opioids, because there's been multiple opioids developed in the past few years, is the sense that there is not an objective biomarker of pain. So the ability of generating, for example, a biomarker that can determine, that have a predictive validity, a biomarker that can also allow you to stratify patients so that if you are developing a pain treatment, you are much more likely to be successful, because we also come to realize that pain is extraordinarily heterogeneous, and so if we are going to have to be successful, we have to be much more targeted. In parallel, there's also the recognition that we need to invest in a more coordinated fashion in the neurobiology of pain. And the budget from NIH invested on pain is $500 million. And you can make an argument that it's not sufficient, more or less. But what is clear is that there are some areas that require specific attention, among which one of the most notable one is what are the neurobiological processes that leads to the conversions from acute to chronic pain, because that's one of the most challenging. And if we can understand it, then you can start to address not only treatments to prevent it from happening, to prevent it, prevention interventions preventing it from happening, but in the process, you may be able to get new targets. So we are currently on this, planning this public-private partnership, and the idea is to be able to hopefully decrease in half the time it takes to get new medications for the treatment of pain, but also opioid use disorders.
I'd like to follow up and amplify on something that Nora is saying. I think that it's the approaches that she's targeting are spot on. I think one thing that was in my slides that somehow got lost in the ether is that pain has a lot of overlap with all the affective disorders that we've talked about today. There's pain circuitry overlaps, and there's a strong clinical correlation between pain and depression. There's strong circuitry and biochemical overlap between pain and addiction. So while it might be nice to focus specifically on pain, we can actually leverage a lot of these studies of other behavioral disorders to actually find solutions that sort of kill 2 or 3 birds with one stone.
You know, talking about overlap with other panels, the last panel was asked the question about stigma, and I was thinking that also is very relevant here. You know, at least from my perspective, stigma has gotten in the way in many instances of our being able to actually apply knowledge in terms of ensuring that certain treatments, medical treatments for addiction, are actually being applied in the healthcare system. Also, you know, there has been, I think, an unfortunate disconnect between the ability to get certain kinds of addiction services reimbursed as compared to other medical services. And of course, you know, there is a stigma that surrounds people in terms of both the medical issue of addiction and also stigma that surrounds people who present with pain. So I wondered maybe each of you could talk a little bit about that in the spirit of this institution, which is really about overcoming stigma, overcoming barriers that prevent us from applying data and knowledge to action.
Well, I certainly agree that stigma exists both on the addiction side and on the pain side, and there's clearly overlap there. And as there has been a focus on reducing opioids, I think patients who are living with pain, you know, if they've been on opioids, now all of a sudden they're lumped into some other category that maybe they were not in before of, you know, they're just seeking opioids because they're addicted or they're selling it or whatever. And I think, you know, we have to look as health professionals of how are we contributing to that. I'll take from the pharmacy side, one intervention that has been largely employed at the state level is naloxone. So naloxone for overdose, you can go to a pharmacy in most states and get naloxone just like you can a flu shot. And what we have continually heard is that pharmacists, because of stigma, won't dispense. Somebody comes in and they immediately are suspicious and they're questioning them. And I think that's on us as a profession to say, look at the magnitude of this issue. These individuals are seeking help. They're seeking in some way to reduce harm for themselves or someone else. As health professionals, we shouldn't treat this in any other way. And I think the corollary with diabetes or other the correlation with diabetes, I was on a recent webinar and sort of brought this up that I think we've all experienced if you've treated patients with diabetes, you know, they lose a toe, they come back to the office, you're not going to stop treating them. They lose the foot, you continue to treat them. They lose, you know, up to the knee, you don't give up. And I think oftentimes people are discharged from treatment the moment that they relapse. And so it is on us as healthcare professionals to change the social norm. And we can do that, and that will likely have spillover effects to the public at large.
We talk about, too, identifying people at risk of addiction, as speaking of stigmas and stereotypes. And certainly there are some instruments that can be used that are helpful in identifying people that would be more at risk than others. But exposure is risk. So although there may be certain characteristics, and we're going to know more about them as our knowledge of the brain advances, individual differences in susceptibility to addiction, there are also, it's mainly, you know, there's this spinning of a large gun with one bullet in it and many chambers. So as you spin that bullet, as you expose people to any of these drugs, so for example, drinking, it turns out that exposing young people to drinking does not reduce their drinking, it increases their risk. It's a dose-response relationship. So many of these things that we think we can tell who's going to develop a problem, and we can tell the things that will prevent it, are not necessarily the case. And this is why those kinds of aspects of identification have to be subject to rigorous science.
And I would say that actually stigma has a big responsibility of where we are right now with the opioid crisis. I won't say that stigma created it, because what created it was the improper prescription practice for opioids, well-intentioned, but basically with overconfidence and in the way that we were prescribing. But what stigma did do was basically remove the responsibility of the healthcare system in terms of their responsibility to screen and to treat those with substance use disorders. So the healthcare system has basically, even though they may say it's a disease, does not incorporate it into what they are supposed to do. As a result of that, as a medical student, you get minimal training on how to actually recognize someone that has a substance use disorder, someone that may be more vulnerable. You actually, therefore, do not, if you're going to be prescribing opioids, for which you also don't get sufficient education or training, you won't even be able to recognize who may be more vulnerable. And if they become addicted, and you do recognize that they are addicted, you will not know what to do from it. So I think that the stigma has basically allowed the healthcare system to wash its hands from that responsibility of addressing the screening and the treatment of substance use disorders. And we need to reverse it, because we don't have sufficient treatment specialized for addiction, but we have a very robust healthcare system in our country. And just like we use it to do screening and treatment for metabolic syndrome and obesity and diabetes, we need to actually train the healthcare providers, and that includes nurses, doctors, nurse practitioners, and pharmacists on the proper, first of all, prescription of opioids, and in the proper recognition and management of individuals with substance use disorders. So that will ultimately erase the stigma. I mean, the moment that we can literally treat a person that has an addiction like we treat other medical conditions, that will basically lead to the change that is necessary for patients to feel comfortable to reach for help, and the families, and to properly put the resources that are necessary to actually deliver that treatment needs on addiction.
Well, let me open up to the audience. While people are going to the mics, I might ask one more question. I think that was a very useful response to the question of stigma, and also how our healthcare system needs to change to better serve our patients. One of the slides, though, that you showed, Chris, really scared me about how we're going to get our hands around this current epidemic with the very rapid increase in synthetic opioids, the fentanyl increase since 2013. Can you just quickly say something about what are our tools to address that? And I see we've got a lot of questions.
Sure. So I think there's obviously a health and a public health component to that. So, continuing to focus on the upstream issues of changing opioid prescribing, not essentially creating newly addicted people. But I think we have to also expand on our harm reduction side of, naloxone, other ways to reduce harms. Awareness is really important. There are studies that say that people don't even know that, what is in their local drug supply. And even local dealers may not know that it's carfentanil or something like that. So I think public health and public safety have to work together to get information out so people can protect themselves, reduce their harms. And then we have to partner with law enforcement. I mean, much of this is not coming from our pharmaceutical supply chain, it's coming in from other countries. And that is, obviously public health has a role there, but also in collaboration with our public safety.
Thank you. Well, people were slow initially getting up, so I didn't think we were going to have so many questions. So let's go very quickly.
I'm Stan Watson from the University of Michigan. I just want to bring a piece of information, basically. I'm aware from the medical side, the pharmaceutical side, that there are systems being developed, compounds being developed in phase 3 that act only peripherally. There are opioid-like compounds, talking to opioid systems, that don't penetrate the CNS. So from the point of view of certain types of pain and certain types of procedures, it may be a rational thing to look forward to, a presence of compounds that don't have an addiction potential, that they don't penetrate into the CNS.
Okay, I don't know that we even need, we all agree, I think.
Yes.
Thank you.
Thank you, that's a very important point. This side?
Larry Green from the University of Colorado. I've really loved today. It's been just terrific. It seems to me that the answer to our question, do we know enough to prevent or reverse major behavioral disorders, is resounding sort of. And what strikes me is that this marvelous organ that we call our brain is built to learn and react to its environment, and that it has the capacity to not only react to it, to be changed by that environment. So while we're enthusiastically pursuing understanding the biologic basis of these disorders to help guide proper treatment and prevention, it seems to me we have at the moment a substantial gap between what we know about working on the behavioral side, the environmental side, to help prevent these disorders and to help treat them, that are readily available and overall not being pursued. There's a difference in not pursuing a yes answer to the question because we don't have the biological mechanisms to do it, versus knowing that certain behavioral interventions like the Bucharest experiment showed can make a difference now. The NAM has been all over this since 2005. I just want to notice something. So many presenters today have said, in my lab or our lab, we have learned the following. What is the lab that brings the biology of these problems to the experience that living human beings have in their communities, where we learn how to use community resources to get going on this stuff? And is that not something that the NAM might want to study?
I think yes. I know Victor is listening carefully, and I think one of the goals of this day's meeting was to really, try to lay out what do we know, what are the critical questions that have to be asked, and how can we apply that knowledge as well as advancing tools and new research so that we can put better solutions in place. So we take your point, and I think Victor is very much in agreement that we need to be doing more work in this area. Next.
Art Kellerman, Dean of America's Medical School at the Uniformed Services University. I want to take gentle issue with the panel on 2 points and invite a response. One was, we seem always to feel compelled to say, we got the country into this mess with the best of intentions. I don't think everybody had the best of intentions. A lot of people made a lot of money. Doctors, pharmacists, retail pharmacies, and manufacturers. And unless we acknowledge that, we won't get out of the hole. But second, the comment was made, we don't know a lot about non-pharmacologic ways to treat pain. I think we know a great deal. We have a center called the Defense Veterans Center for Integrated Pain Management at USU. SEALs, Special Forces guys, nobody would mistake them for wimps. They're doing yoga, battlefield acupuncture, mindfulness, a number of techniques that are showing to be profoundly effective at managing chronic pain without the need for opiate analgesics. And they have a fabulous primary care curriculum that's available to anybody in this room in any state in the country. Partnering with West Virginia right now in the Commonwealth. There's a lot we know that can work, that can get ahead of this and prevent these folks from getting hooked in the first place.
I think that's very true. We also need to make sure it gets paid for.
Morning, Lichtveld, Tulane University. You would have thought we would rehearse these questions or observations. Here is a holistic way to deal with it, and it's learning globally to apply locally. In Suriname, we have a very unique problem, and actually in the Caribbean area, and that's pesticide-induced suicide. It's highly risk-taking, early adolescent behavior risk decision-making, and stigma, just loaded with stigma because they could go nowhere. No psychiatrist, no warm line, no hotline, nothing worked. What has worked for us currently is to train community leaders as pesticide interventionists, as community health workers, who then, connected to mobile health technology, they can intervene at the attempt phase, not when the suicide is already happening. And so I'm sharing that with you.
Thank you.
Quickly squeeze in all the remaining questions before our hard stop at 4.
It's been a terrific day and a terrific panel. I'm John Dreiser from the Tennessee Department of Health. I'm the commissioner there. I've got 2 questions on marijuana, another addictive drug that I'm deeply concerned about, and its purported potential use for treatment of the very challenge that we're talking about. And I feel like I've seen that movie before, starting in the 90s. And then the issue of buprenorphine, which several have alluded to, struggling right now in my state to translate all the brilliance that I've heard today in the earlier sessions and today into actionable policy. And specifically right now, there'll be a bill, in my legislature this year on whether or not marijuana should be legalized. We're still a state that has not done that. I'm deeply concerned about the impact of that herb on the health of the population in the United States. Secondly, buprenorphine. We all agree there's a need for treatment, and there are insufficient treatment providers. But what I'm also hearing, and I'm very concerned about, is even as somebody who did medication-assisted treatment therapy myself, I have it's through a glass darkly to really know who's going to benefit from that treatment. You walk through my office and I assume you want it, and I assume that that's something that might be useful for you, but I don't really know if I should detox you to abstinence. I don't know if I should taper you on buprenorphine. I don't know if you're a good candidate for buprenorphine generally, and that molecule is being rapidly supplanting other molecules in parts of my state. So my plea is for help with translating this into policy in real time, and as an earlier questioner just mentioned, I think there's a lot of stuff that we can use to help inform evidence-based decision-making, but it's hard to separate fiction. And I'd love your
let me
comments
ask
on that.
Nora to take a quick crack at that. Valerie may want to opine as well, but I'm going to warn you, I don't think we're going to be able to take all of our questions because we do have another important panel to come.
Well, let me start with marijuana, and indeed there's not sufficient evidence actually about medical marijuana, and the way to address that is actually to do the research to determine under what instances and what are the active ingredients that may have some therapeutic benefit. But that has not been done, and yet at the same time, many of the states have legalized medical marijuana for its medicinal purposes, so that's something that we need to address in terms of research. The other issue is how harmful is marijuana going to be, and we're particularly interested on its negative effects to the developing human brain. And that ultimately was the reason to initiate this project that has been mentioned already 3 times, ABCD, in order to actually follow prospectively 10,000 children and look how their individual brain developmental trajectories and how it may be affected by drug exposures, so that we can unequivocally understand how drugs may influence those trajectories and use that hopefully in policy, because not necessarily policy is based on science, but we want and hope that it will be. With respect to the buprenorphine, your questions are actually among the many that have not yet been resolved, again highlighting the importance of being able to do research that allows us to evaluate longitudinally the outcomes on individuals that are suffering from an opioid use disorder, so that we can optimize the best care for them. And one of the things that I would hope that emerges as this crisis is evolving is something that we have not done for the treatment of opioid use disorders, is that we demand quality of care, not just care, quality of care. And that will obviously require that we do more understanding, and so that we can predict what patients may respond optimally, one treatment versus the other.
And continuity of care.
Yeah, continuity of care, the chronic model of addiction. I wish we would treat it like an antibiotic, no, you need continuity of care. We don't know how long you have to treat someone on medication-assisted therapy, but we know the best outcomes occur on patients that have been treated for 5 years.
Okay.
Thomas Reyna, NIH, quick question. As a cancer patient, I feel I have to stand up for opioid use. Nora, can you reflect briefly on why cancer patients do not get addicted, or they do?
Well, you know, one of the things that at one point we were taught, and still is some thought, is that if you have pain, you are not going to become addicted. And what has emerged is the fact that that is not correct, that people that have pain become addicted to opioids. And even in animal models, you can generate that. Specifically as it relates to cancer patients with opioids that don't become addicted, I don't know that I have seen sufficient data to know that is the case. So I don't know. I mean, it's an N of 1, and we shouldn't be driven by N of 1s. I mean, not everybody becomes addicted that get exposed to a drug. Some have greater vulnerability than others.
Thanks.
All right, very, very quickly, a nice succinct question, a nice succinct answer.
Jim Perrin, Mass General Hospital for Children. Do the FDA and other agencies have the appropriate authority to regulate drug distribution and prescribing to have some impact on this epidemic?
Well, I know that the commissioner of the Food and Drug Administration has come into the room, and perhaps we should leave the answer to that question to Dr. Scott Gottlieb and the next panel. So thank you all very much.